So hello, everybody. My name is Nina Crowley. I'm SECA's Professional Affiliations and Education Manager, and I'm really excited to be talking to you today about the impact of aging and obesity on muscle health. I think this is an area that is becoming more and more important to all of us, and we're going to be going through the complicated and nuanced components of obesity, aging, and muscle and adipose tissue as well. First, I just wanted to review sort of what we are going to talk about today. So our objectives are to identify how the disease of obesity is related to inflammation and cognitive decline in aging, and integrate sarcopenia and muscle mass in assessment of older adults with obesity, describe the effective strategies for managing and measuring weight and muscle in aging adults. And I do want to leave enough time at the end for questions or for people to share their experience. So please do, as we're going along, include that information or questions in the chat box so that we can have a good discussion. It's always tough being on this side where, I'm talking to you, but I really want this to be a conversation. And so I really appreciate all the sharing of your clinical and personal experience. Okay, so I first want to, kind of level set and talk about obesity as a chronic disease. This is something that I think all presentations about obesity need to address, is really how we are framing obesity and severe obesity. So, there's a real kind of baseline understanding that obesity is a disease, but this is not something that even all the public or even all healthcare providers really embrace. And so I always show a version of this slide where we are looking at, this is not all the studies, but a significant amount of research studies at the time. This was published in different areas for causality for obesity. So I show this because it's very complicated, but that there's areas within each category. So there's not a one size fits all reason that people have obesity. This is, for anyone working in this field, you never sort of talk about this at a dinner party, right? Because people will come up with their explanation or want to know, well, what do you think this is? What do you think this is related to? We're just not walking to school anymore, right? So this is something that, I think it's important that we all continue to talk about how it's complicated. It has as much as 40 to 70% heritability, genetic component. It's a worldwide concern, of course, but it's very influenced by many different factors. And so I think it's less important really that the conversation be about what is causing obesity as really what can we do to treat and then hopefully prevent moving forward. So I do think it's also important here to talk about it's not just about food. It's not cured by a miracle, single cause, or single treatment modality. It's not yours to manage alone. I think that's a very important message that people hear when we talk about obesity. So I did want to share most recent obesity prevalence statistics as we're setting the stage here and talking about the number of people in the US that do have obesity here. In all of these sort of epidemiological type studies, you're going to be looking at prevalence of obesity with obesity categorized as a BMI of 30 or higher. And so in 2021, that most recent number was 41.9%, with a breakdown here of the different racial and ethnic minorities here, because they do have different percentages of prevalence. So I think that's another important piece as we talk about this. Since we're talking about older aging folks here in today's presentation, I wanted to break that down for you by ethnicity and race for people over 65. And so here you see that number that was 41.9% in everybody, adults, decreasing to 33% in the top line here, 33% for American Indian, but breakdown by each ethnicity here. And then if you look at here down at the bottom, 29% for Caucasian or white category, but varying very, quite the range for the different ethnicities combining to that average number. I thought this was actually another important slide to talk about here, the BMI over 40, which in this regard, they're considering that severe obesity. This is also, to me, interesting in that 9.2% is the total, but also that we have a disparity even between men and women. So with women having a much higher severe obesity prevalence than men, and then you see that sort of dipping down after the age of 60 in that category as well. So 5.8% with severe obesity in that older category. And again, disparities by racial and ethnic groups. So prevalence, of course, I think that's important. We all know at some level that this is something that is now infiltrating everybody's practice. But here, I wanted to show you how obesity does accelerate the onset of disease. So if you're looking at the bottom on the x-axis, you see obesity, or you see age here on the x-axis, and on the y-axis, you're looking at the severity of disease. So as people are getting older and severity of disease is going up, you see the differences in those colors for normal weight under BMI of 25, overweight, obese, and then obese with other unhealthy lifestyle characteristics. So really just showing here that the onset of chronic disease is younger in the groups that have higher weight, and even higher in those who have these other sort of lifestyle characteristics as well. So we've got sort of shortened lifespan there, and we've got kind of component of threshold of disease starting at an earlier age. So of course, talking about obesity, we need to kind of talk about what are the clinical consequences, and why are we, even talking about weight as being such an important factor here. The clinical consequences, we could talk about that for a long time, but range from endothelial dysfunction, increased risk of dysfunction on multiple, organ systems, all sorts of, different disease states. I've heard, 200 plus disease states impacted by obesity. The burden of disease, the multiple medications, disability. We could also talk about weight bias and how impactful that is. That's a whole nother talk. But even impact on mental health, dysregulated nutrient sensing, increased risk of cardiovascular disease, cancer, and that tends to get the attention of, that gets the attention of folks from a cardiovascular perspective. So the other components of high blood sugar, high blood pressure, and high blood lipids. So we do know there are lots of clinical consequences of having elevated adiposity. So what we really wanted to talk about here is how obesity can cause a state of low-grade chronic inflammation in the adipose tissue. And so that adipose or fat mass tissue, that leads to dysregulation of the homeostatic system, and that leads to development of the various diseases, including those that are related to neurodegeneration. That neuroinflammatory process can actually change or damage the neurons in the central nervous system, which results in a loss of neural integrity or neurodensity, neurodegeneration, and that can lead to cognitive decline. So we have obesity superimposed on aging, which can increase this chronic low-grade inflammation. Some call it inflammaging, and that is an important link between obesity, insulin resistance, and these age-associated diseases. So a little bit deeper look on the adipose tissue. So adipose tissue is also known as fat tissue, fatty tissue. That is composed of lots of distinct cells and molecules. So adipocytes, macrophages, other immune cells. And this tissue is actually considered an endocrine organ because it secretes pro-inflammatory adipokines and cytokines. And that is what triggers inflammation, the oxidative stress, and then insulin resistance. So this is kind of the pathway that we're talking about. Increased weight when it's from adipose tissue can be problematic. So you've got inflammation, oxidative stress, and insulin resistance that we're looking at here. I think it's important too to think about the excess adiposity and brain health, because that does have a connection, and the location of excess adiposity matters. So I like to show this as an MRI, kind of a slice of where the adipose tissue lies. And so the outside in that teal is the subcutaneous fat that's between the skin and the muscle. The yellow there is the visceral fat. That's the tends to be located in the abdominal area. And then, intramuscular, which is a very small amount. And then red would be that skeletal muscle. This is important because this visceral fat is a much more active and inflammatory type of fat. It's related to that higher dementia risk. It's associated with brain atrophy and reduced brain volumes. This was a new study, this Raji et al. Study down here linked, was a new study this week, or this month actually, showing the brain atrophy and reduced brain volumes with increasing visceral and also increasing subcutaneous fat. So we see here that visceral fat plays a role in cognitive decline and the dementia risk through these inflammation-related mechanisms. So this is, we're not just talking about obesity as weight. We're not just talking about excess adiposity. We're also talking about where that's located. And that's where this visceral fat component really does come into play. Yes, I do have the links. I have the references for all of the studies at the end, and happy to share links to those as well. I saw that question come in. Okay, so now I wanted to shift a little bit into a talk on the component of muscle mass, and sarcopenia. Can I get rid of that? Okay. So here, I think this is a really good way for me to visualize sort of how these three things are related. This vicious triangle, we say, between aging, sarcopenia, and obesity, which can cause sarcopenic obesity. So elderly are prone to be negatively affected by this vicious cycle. And aging and sarcopenia here in blue and red are associated with low muscle mass and strength with increased catabolic signaling. Aging and obesity there in green have a closer relationship through high lipotoxicity, oxidative stress with dysfunctional adipose tissue and inflammation, as we said. And then sarcopenia and obesity at the bottom can aggravate each other by decreased basal metabolic rate and low physical activity. So all of these associations can be an accelerator to that sarcopenic obesity state characterized by high fat mass, low quality muscle, insulin resistance, and that inflammaging, along with mitochondrial dysfunction and muscle and adipose tissue dysfunction. So complicated relationships, but we're going to kind of go into the sarcopenia and the muscle side of that now. I like this chart here on the left because I think this shows us, as we're aging, our muscle strength really does peak in that midlife and then starts to decline. We know, people love to talk about the negatives of aging, but I think this is really, one of the factors that's a reality where it's coming back down for range of strength, but it doesn't have to be as low as what we see. So that's where that shaded area shows you where the muscle strength is going down. But if you work on the factors that are within control, we are able to keep that sort of that slope of that line less of a deep decline. And then I like this picture here on the right because this really, to me, illustrates the kind of the idea of what sarcopenia is. If you're looking at someone's, say their arm here, the size of the circumference of it may not change, but what's inside does. And so you're looking at, bone, muscle, and fatty tissue, and you're really seeing kind of a swap between fatty muscle increasing, fatty tissue increasing, and then the muscle mass decreasing. And so that's where we're going to see that healthy muscle mass turning into that muscle loss in sarcopenia. The number that I hear the most, and I think is most kind of visual for me, is that our muscle mass decreases 3 to 8% after age 30 per decade. And then that is an even higher decline after 60. So this is something that is very important to all of us. And it's almost like if you can get people to really understand that before they're in that phase where it's hard to build back, that's really the goal. So this younger age, when people have the chance to do a better job at increasing their muscle mass, is really important. Another kind of pathway to go through, talking through atrophy of muscle fibers, which relates to the decrease in the number of the myofibers. You've got aging-related alterations in protein synthesis. So that is, what we're saying. It's harder to grow your muscle mass through complicated, pathways of protein creation. But that does relate to loss of skeletal muscle and then impairment and cognitive impairment and dementia. So the not only is the adipose tissue pathway changing with age, but also this muscle mass pathway as well. So the loss of muscle mass related to cognitive decline comes through these different pathways: the altered myokine secretion, inflammation, insulin resistance, and abnormal protein accumulation, oxidative stress, and then mitochondrial dysfunction. To me, this is all very high level. It's hard to really wrap your arms around what this means for the individual, but I did want to give you the background of these are all things happening in the background that happen when we do lose muscle mass. So that loss of muscle mass really has a connection to cognitive decline. I wanted to show you this is just a couple different studies showing the different ways that muscle and strength loss occur with aging. So over here at the top, they're losing, this is leg lean muscle mass showing 1% a year, where the strength is being lost 2 to 4% a year. The loss of lean mass in the legs at 1.3% and strength loss 1.7 to 2.5. And then again, 1 to 2% after the 50th year. So these, there's lots of different ways to represent these numbers. I tend to like that 3 to 8% by decade until 60, and then faster after that. I think that's a nice statistic. But I do think it's important to kind of delve into what these mean, by year and then by decade as well. And then really to put it more simply, aging and obesity have impacts on decreased muscle endurance, increase those pro-inflammatory cytokines, increase the lipid infiltration of the muscle, and that all muscle disuse and wasting, sort of the decrease in physical activity as well, all result in this reduced muscle quality and function. And another way to put that, again, in a more cyclical version here, showing the chronic conditions with excess weight and adipokines, inactivity, disability, attrition of telomeres, neurodegeneration, along with poor diet and low intake, malnutrition, hormonal factors, inflammation, and then that mitochondrial dysfunction. So that is sort of this vicious cycle that we have going on in the background for all of us. And so this is something that is very important, not just to yourself, but of course to all of your patients. Again, that muscle and cognitive functioning, I did want to share here, just how, that low muscle mass and the increased in executive function decline is actually regardless of body weight or strength. So this is just happening as muscle mass is going down, regardless of someone's weight. We do have cross-sectional studies that support an association between muscle strength and cognitive function. That's the strength component. And then that poor muscle strength and cognitive function, there's a bidirectional association as well. We can also look at things like gait speed. So someone's gait speed is associated with their cognitive function, and hand grip strength and low muscle mass are both independent risk factors for cognitive decline. So a few different ways to be categorizing that and kind of looking at that impact on cognitive decline. So I showed you kind of that cartoon of the sarcopenia in the muscle, right? But here's what it would look like in actual, MRI here, where you're looking at a young, healthy thigh muscle with a sarcopenic thigh muscle. And you see that dark, lighter color of muscle is really decreasing. The outside ring there of the fat adipose tissue is increasing, but you do see a little bit of a difference in size. But again, if you just were looking at the look or the weight of someone, you would not be able to see this as, impactful as you do this way. So there's a few different ways to define sarcopenia. These are the three that I think are the most easy for me to visualize, where you have progressive generalized skeletal muscle disorder associated with increased likelihood of adverse outcomes, including falls, fractures, physical disability, and mortality. Or the loss of skeletal muscle mass and muscle strength, which is a prominent feature of age-related change in body composition, and the deterioration of skeletal muscle composition and quality in combination with increased fat mass. So these are three different ways to think and talk about sarcopenia. I also think it's important, really just the take home is that as your muscle mass declines and your fat mass increases, the weight may even stay the same. But the reason that we care about this in a sarcopenic obesity state is that you can see that reduced mobility, reduced energy expenditure, which is going to have a lot to do with, keeping their weight at a certain level long-term, positive energy balance, weight gain, that fat infiltrating the muscle, as I'd mentioned. Muscle doesn't regenerate as well, becomes harder to contract, and it doesn't work as efficiently. So these are all factors of that sarcopenic obesity state. Another way to visualize that here, we've got these inputs here, insulin resistance, inflammation, oxidative stress, hormonal changes in physical activity, all impacting this sort of synergistic interactions between sarcopenia and obesity related to all of these sort of health outcomes that are important. Other ways to phrase that would be a decline in physical function, lower skeletal muscle mass, lower muscle strength, endurance, balance. Got a lot of, falls, fractures, caregiver dependence. This is really important to people, in these type of facilities where we're trying to keep people as healthy as possible for as long as possible, minimizing the impact of disease like diabetes, cardiovascular disease, and then, of course, all of the cognitive components, nutritional inadequacy, and then, even outcomes like frequent hospitalizations, post-op outcomes if folks do have surgery, increased depression, and poor quality of life, which, again, we could talk about mental health and aging as well. So I think all of this to me is it's overwhelming in how much there is in this category of obesity, sarcopenia, excess adiposity. And what does that look like from an actual prevalence standpoint? This is from a presentation through the Obesity Medicine Association, where they talk about sarcopenic obesity affecting 28.7 million adults. The prevalence of that being 15.9% in the total population, in the younger 20 to 59, 8%, but in that over 60 category, really that 28% of sarcopenic obesity. So this really is something that we need to pay attention to. Talked about cognitive decline, but I wanted to mention, of course, this leads to a discussion about dementia and Alzheimer's as well. So when we have obesity and sarcopenia together, we have that increased inflammation, decreased neurotrophic factors, and then neurodegeneration. There is a loss of brain volume, which is related to that cognitive decline, and that has an impact on dementia. Just to show you, a study here looking at a control group and those kind of separating out those with just obesity, those with just sarcopenia, and then those with the combination, showing that the combination of sarcopenic obesity is independently associated with mild cognitive impairment and dementia. And here also they showed that having a BMI of over 30 and central adiposity, so where your waist circumference is elevated over 35 inches in women and 40 in men, that was also associated with increased dementia and, independent of some of the demographic variables as well. So again, not just where the weight is total, but also where it's located. And then another interesting component here, I think, is looking at midlife obesity. So it's not even just the age, at any age that we're worried about this, but it does have some different effects at different points in life. So here, obesity, but not overweight in midlife, was associated with later life dementia. So what that means is really that a little bit of excess weight in midlife actually seemed to be more protective than lower weight at all, or those with obesity. So the 47% higher dementia risk was associated with obesity in midlife compared with a normal BMI. So we'll come back to that in the end, I think, and talk a little bit about when do we talk about treatment and when do we say that a little bit of extra excess weight or adiposity is okay and can be actually protective, and when do we start to really focus on that specifically. Okay, I wanted to share here a algorithm of sorts. There's a few different ways we can kind of talk about what do we do and how do we assess this, but I liked this way of looking at the severity of sarcopenia here. So this is, finding cases means how do you screen out someone? I'll show you on the next slide what this simple screening tool looks like. and then assessing through grip strength or a chair stand test. And that can tell you, if that person has no sarcopenia, rescreen later. If it's sarcopenia probable based on the grip strength and chair stand, in clinical practice, it might be enough to trigger assessment and start intervening. You may want to move on to confirm that sort of diagnosis with looking at muscle quantity or quality through DEXA, bioimpedance, CT, or MRI. We'll talk more about that as well. And then if that confirmation is sort of confirmed, if that sarcopenia is confirmed there, you would look a little bit more into the severity of it and see, gait speed, looking at some of these other maybe physical therapy generated testing to see how bad that is. So I'll show you that next slide. And the European Working Group, this is where this came from. So this is obviously a much more in-depth document to take a peek at if you're interested in this algorithm. The screening instrument, just very basically looking at the different categories here with a max score of 10, but a score greater than 4 requiring evaluation. Just asking people difficulty lifting and carrying 10 pounds, how much difficulty walking across a room, transferring from chair to bed, climbing a flight of stairs, and how many times have you fallen. So they've shown that those pretty simple questions are enough to screen and kind of move them on to the next phase. So I think that's something that no matter what your field is, that's something you can kind of include in clinical decision-making pathways as well. And then when you get to that assessment component of muscle strength and quality, how do we assess that hand grip strength, muscle strength through hand grip strength and a chair stand test, the knee extensor strength test as well. These are things that, the chair stand is measuring how long it takes someone to rise 5 times from a seated position using their arms. And then the time chair stand test is a variation counting how many times they can do that within a 30-second interval. And then confirming that muscle quantity, looking at either DEXA for appendicular skeletal muscle mass or bioimpedance with the whole body skeletal muscle mass and the appendicular skeletal muscle mass. So these are ways that we can, kind of more practically then assess what do we do if someone has low muscle in those categories. So to get a little bit deeper on those, the DEXA, CT, MRI, these are considered your reference methods. So this would be, identifying low skeletal mass in elderly and people with chronic disease. The reference methods is limited in clinical practice. So what we use instead in my world is we use bioimpedance analysis, where that is validated to those reference methods. So you measure someone for skeletal muscle mass, that would be with an MRI, you measure that, and then you do their bioimpedance analysis with the predictive formulas, and those are about 97 or 98% accurate. So we feel confident in using the much more simple and clinically applicable bioimpedance analysis to assess their muscle mass, knowing that it is quite well suited to predict what you would get from an MRI, which would be considered that reference method. Bioimpedance relies on validated equations, so you do have different devices that are validated to DEXA, to CT, to MRI, but in general, the message here is that it is feasible and efficient in a clinical practice setting to be assessing through bioimpedance, and we can feel confident that it does match up with those reference methods. Scooted along too quick. The multi-frequency hand-to-foot bioimpedance. So what that means is you're using multiple electrical current frequencies, and hand-to-foot means you're putting the electrical current through the feet, out the hand, so that you can really assess the whole body. That is really what we see as standard of practice, and that gives you parameters for muscle mass like fat-free mass, total skeletal muscle mass, segmental, so in the different arms and legs, torso, and then the appendicular skeletal mass, again, looking at the appendages, so not the torso. Also fat mass here, we're looking at body fat percentage, visceral adipose tissue, and then information about total body water and extracellular water to monitor and trend. And those do have implications in older adults as well. So Obviously, I think bioimpedance is a really applicable and important way to assess muscle mass, but we do have some options in this field now with screening and assessment tools as well. So I do want to talk a little bit about some strategies for managing, measuring, and maintaining weight and wellness. And this, again, as I started talking about obesity as a chronic disease, I think this is really important that we talk about this systematic approach. And this is a snippet right from the Canadian obesity guidelines, which I think are fantastic. They do a really good job, including a lot of the behavioral and psychological components, including information about bias and triggers and all of these things. And so what they talk about when they're talking about assessment of obesity is gathering information to talk about the severity of the disease and comorbidities, looking at triggers and drivers, and guiding the discussions in a non-biased, stigma-free clinical setting. That's something I'm very passionate about, because I think we in healthcare have gotten this wrong for a number of years, where people who have the disease of obesity, have experiences with bias. They don't come back for treatment. They stay away because they felt so stigmatized by their healthcare providers. So I think it's all of our job to do a really good job making this an inclusive environment without bias and stigma. And part of that includes, how are we talking about weight? How are we talking about goals and values, and really getting that patient-centered approach to have them direct their management. So their accountability and their self-directed management are really important in all of this. So some ways to open that conversation, really at first asking permission to discuss weight and their health, using person-first language. This is still, as long as I've been talking about this, it is still crazy to me how often we see people being labeled by their disease. So instead of saying an obese person, we would be saying a person with obesity, a person with affected by living with something like that. It's a really more positive way to frame this, and it does provide, again, more hope. And when we're talking about this person-centered care, it's really important that we get this right, that people feel that they're being treated with respect and compassion, that it's a partnership, that your goals are worked on together in a patient-centered way, and then really having that, like, what matters to you conversation. So you might not have someone who cares all that much about, what they look like, what their health conditions are. But for them, what really matters is being able to get on the floor with their grandkids, or being able to move, or be able to do, maybe more functional things. And if that's what they care about, that's where this conversation goes. And that's how you frame goal setting and, why building up muscle is important to them. Other people have, I had a lot of patients who were very focused on specific numbers. And so for them, that mattered to them. And that's how you focus those conversations and move forward with goal setting. So conversation about this is also as important as some of that more heavy kind of scientific stuff that we talked about, because behavior change is complex and not easy to just do what someone tells you to do. So again, a whole nother talk on how do we motivate people and use our counseling skills to get people to change behavior. But I did want to kind of put that in the framing of all of this. I do think this is not super new news to most of you, but I do think it's important to remind folks that while we tend to use this in clinical practice as a proxy or as a measure for obesity, BMI does not tell the whole picture. So we know that it's not a direct measure of body fat, cardiovascular risk, or health. It doesn't show the distribution of body fat. It doesn't account for muscle mass. We know most, lay people also would understand that it underestimates body fat in people who have lost muscle, and for people who are more muscular, it would sort of label them as obese, or a person having obesity, where their body fat is very low and their weight is related to their increase in muscle mass. So you've kind of got people on those ends of those spectrums that illustrate that nicely when you're trying to convey this topic. But it also, BMI is just weight divided by height squared. So it also does not distinguish, with different goals for men or women, or ethnicity, where we know different ethnicities may have different weights or body fat percentage that's related to chronic disease at a different level. So we've seen some movement in BMI. I've seen this in some of the policies where Asian ethnicity at a lower weight or at a lower BMI experience effects of cardiovascular disease. So the cutoff for obesity instead of 30, maybe 27.5. And I've seen some movement towards African-American patients where a higher BMI might be related to disease. So they could be a higher weight, maybe BMI 31 to 33, before they're seeing risk in that same category. So I think we'll see a lot more to come on more specific ranges based on ethnicity and gender. But overall, we do know that this is a screening method. I don't see this going away altogether anytime soon, but I do think it's important that you share with your patients kind of some of that nuanced language around it. And knowing that it can be less accurate in the elderly, in the young, people with physical disability, severe obesity, pregnancy, or anytime they're sort of carrying excess water weight. It also underestimates in certain ethnic groups. So the take-home message here really is using BMI as part of that clinical evaluation, but not as the sole measure, and really getting into some of these other ways to talk about excess adiposity, low muscle mass, and some of these other factors with sarcopenia. So I do want to kind of put that out there with obesity classifications. Right now, we're still looking at the general population as a BMI of 30 being called obesity. So when you look at studies or any of those graphs that I've showed, that's really what they're using as a cutoff. For the individual, we do think that the where the fat is located, so visceral fat is a better assessment, and I'll show you that on the next slide. But also, that another way to look at that is that central abdominal obesity. You can start to use something like waist circumference. That gets a little bit more specific, where you're measuring around the abdominal area to assess, that's where when the excess weight is in visceral adipose tissue, it's around the organs around the abdomen. And so measuring that gives you another piece of data to sort of help really clarify this person's individual health risk. So there's some cutoffs there as well. And then I pull a lot on the Obesity Medicine Association. They have a fantastic algorithm that'll be linked in the references as well. But they've taken a few different kind of classifications for body fat and have come up with their classification. So what's tricky here is we don't have a number that's like nationally or internationally agreed upon, like if your body fat is this, that equals obesity, but we're getting closer. So with the OMA categorizing, they would say for men 25 to 30, and for women 30 to 35 would be pre-obesity or overweight. That would be the other word that we've seen. And then obesity would be for men over 30 and for women over 35%. So getting a little bit more towards an actual cutoff that we're comfortable with based on gender. But again, looking at where the body fat is distributed, and their recommendations here for optimal visceral fat would be that we have less than 1 pound of visceral fat and less than 3 pounds of android fat, and then total fat and body fat for men and women between 70 and 80 pounds would be the average. I don't see the optimal there, but average visceral fat would be 2 to 3 pounds for women and men, whereas the optimal would be under 1 pound. So again, looking at some of these kind of benchmarking numbers and where we're really kind of moving towards getting better specific cutoffs for people to look at. When we talk about treatment options, again, for those of you who are here who are doing this every day, this is really just a review or a way for us to anchor and look at this as it is not a either or. It is a very much in treatment approaches based on intensity, and that patient-centered approach of looking at the provider and the patient and saying together, what are your health risks? What is the treatment options that we can undergo together? But we kind of look at this based on a weight loss % of total weight goal. So again, as I'm saying, we don't want to be fully just using weight and BMI. We tend to see these goals still be based on a total weight loss. With some caveats of how to look at, body fat percentage and muscle mass as well. So you've got these multi-component intensive behavioral interventions that can help typically 2 to 5% of total weight. More specific nutritional interventions that are more targeted or more prescriptive, 5 to 10%. The pharmacotherapy, we still do see, especially with insurance, these cutoffs being BMI 27 with health conditions and over 30, and that 5 to 20% goal weight. I think we're really seeing that being pushed with some of the new anti-obesity medications out there, over 20%. And then there's endoscopic procedures like the gastric balloon and the endoscopic sleeve gastroplasty, seeing 10 to 20%, maybe even higher than that. And then with surgical weight loss, so gastric bypass, sleeve gastrectomy, the other bariatric or metabolic surgeries with 20 to 40% goal weight loss. So again, numbers here really being used to target what the goal is for the person. But then I do want to talk about how we overlay these type of goal settings for the person who's aging, and where that person is and what their goals are for functional capacity and, their life goals as well. So when we talk about how to measure and evaluate outcomes, pulling from the OMA slides, I really love this slide because this is showing a very simple image here of someone's weight loss. So if this is where they're carrying their extra weight, what we're looking at is, say this person lost 100 pounds, just for ease of numbers, on this scale here. The composition of their weight in fat mass, we're wanting that to be at least 70% here, and we're aiming to decrease the lean mass loss below 30%. So this is saying if you lost 100 pounds, we want you to lose less than 30 pounds of lean and more than 70 pounds of that as fat mass. And so these are at least some very basic kind of goal setting kind of benchmarks for where that weight is coming from. The way that you would assess this would be sort of at first, maybe change in weight and trending with BMI, but then really looking at that body composition where you're looking at fat mass and body fat percentage. Fat mass is total pounds, and body fat percentage would be pounds of fat over total weight as the percentage. Looking at where that's located. So that visceral adipose tissue is important to be able to assess the skeletal muscle mass, and then the fat-free mass or lean body mass. That's really a bigger category when you're talking about body composition. You're looking at what is fat mass and what is everything else. And so that's one way to look at it. And then you can drill down further to look at that actual skeletal muscle mass. And then the appendicular skeletal mass, that's the lean mass without bone and fat in your limbs. That's another parameter I'm seeing more people talking about as well. When we're looking at outcomes, of course, we're looking at how health conditions are impacted. And then, we can't minimize the effect on mental health and quality of life, which are super important, to be talking about with patients. So kind of coming back to sarcopenic obesity specifically, and these treatment goals. The big thing here, we want to reduce the adiposity, right? So the excess adipose tissue, that is that inflammation part that's contributing that component, that is not what we want. We want to preserve and gain muscle, preserve as much as possible, especially during the active weight loss phase, and then gain muscle mass in function as much as we can. We want to reduce these health risks and any connection to the chronic diseases, and then of course improve health and quality of life. So our challenge here in this blue circle is that in our aging population that is prone to loss of muscle mass, how do you preserve muscle while creating an energy deficit and prevent that most of that weight loss being from fat-free mass or muscle mass? Think back to that picture with the person with the yellow and the red. We really want to prioritize that because it is, as you may know, experience yourself, very hard to build back muscle once you've lost it. So these are some components that I think are important to consider as we talk about aging on goal setting for weight management. So we want to make sure that people are staying independent and maintain physical functioning. That's a big one. And people might not phrase it that way, but if you listen to their language, that is a big goal for people. So really relating some of the stuff that you're talking about from a recommendation perspective to what their goals are. A big goal would be preventing further muscle loss. So it may not be gaining it. at this point, it may just be preventing further. It may be looking at bone loss and aging as well. And we want to be sure that a calorie deficit is not contributing to too much weight loss, too much muscle or bone loss as well. We also know that setting discrete clinical goals of the drivers of the decision for weight loss is important. So what that means is really, kind of weighing that risk and benefit, where, we're not just saying to people, you just need to lose weight. Weight loss alone is not what we should be recommending. But what are those clinical goals? What can you measure? What can you check in on? And really having that risk benefit conversation. I think it's very important to consider that energy needs go down as we age. So if you look at a lot of the parameters for body composition, as people age and their muscle mass tends to decline, as I showed you, their resting metabolic rate goes down as we age. And so calorie needs go down, and yet we're seeing certain nutrient needs go up, vitamin D, calcium. And so we have to figure out how to balance that and make sure that translates into some of the nutritional recommendations we have. Considering social isolation, limited access to food, transportation issues, food insecurity, these are all things that impact aging populations. And so it's not responsible to just, tell people, hey, just lose weight, go out and, exercise here and buy this and do that. We have to really, to get it to work, it's got to address some of these barriers that people experience. And then sleep and cognitive decline and central adiposity. That's another kind of interesting pathway that I think sleep just never, it's kind of like the last thing, right? We talk about nutrition, we talk about physical activity, we even talk about behavior, but a lot of times sleep doesn't really get discussed. And that is another very important part of this conversation. So then I mentioned this earlier as weight being a possibly protective factor. I just wanted to flesh that out a little bit here and talk about that. Most of midlife is where these interventions for weight management are taking place. So I know for me, when I worked in bariatric surgery, our average patient was age, 43 or 43 to 47. But we do have people, of course, on both ends of the spectrum, younger and older. But a lot of times that higher BMI later in life is actually associated with better cognition. Oops, sorry about that. So that's not a, something to pass over. That's saying that it may not be prudent to recommend, a lot of weight loss, significant weight loss for someone who's older, because we might need that to protect their cognitive abilities. We've seen weight loss in older age related to cognitive decline and increased risk even for Alzheimer's. So this is later in life may not be the time to be really recommending fast or significant weight loss. Again, individual patient conversation, but I wanted to mention too that Alzheimer's can be known to develop before they actually have cognitive symptoms. So if low weight in old age is a manifestation of that early stage of disease, it may actually be a sign of that premature brain dysfunction. So it's something to think about. We do want to be looking at, someone's history of their weight and changes in body composition as they get older. But again, thinking about how that could be predictive of the brain dysfunction later. We'd want to focus on protecting and building lean mass during midlife. I think this is really where it's at when it comes to, people are kind of sick of being told to lose weight without a lot of, constructive ideas around that. But I think what we don't hear enough of is how important it is to build lean mass during midlife, and maybe less focus on the weight and adiposity as they get older. So that to me is a big take home here as well. And now how do we accomplish some of this? I did want to, this is again, a whole talk on, what are the real practical ways to do this, but calorie restriction that leads to loss of fat mass can also be known to be accompanied with loss of skeletal muscle mass. So again, just like that picture, if someone's losing weight, we can't prioritize necessarily and say, we want this to be all from fat and we'd like to keep our lean mass. That would be ideal. But we've got to monitor it, right? So we've seen, about 20% of weight loss when someone's on a low calorie diet tends to be skeletal muscle or lean mass, depending on the study. What parameters are we comfortable with? And, how do we intervene when it becomes higher than that? I've read here and seen in this study that the optimal or safe range of energy restriction for sarcopenic obesity is an energy deficit of about 200 to 700 calories per day. And then again, as I've mentioned this a few times, placing sole focus on weight loss can have harmful effects. So we want to really make sure that it's not just blanket advice to lose weight, that we're really looking at muscle mass, micronutrient status, bone mineral density, and all of those other factors as well. So combining with a lower calories, we also would want to talk about diet and exercise interventions. So this was, I thought, a nice chart here to talk about combating loss of muscle mass with calorie restriction alone. Needs to include protein intake, resistance exercise, and aerobic exercise. So they give you some guidelines here for the dietary intervention, and actually put some numbers around that. But I think this is a lot, like 60 to 75 minutes, 2 to 3 times a week, focusing on strength, balance, and flexibility. Maybe more than is really achievable. But if we look at that as maybe a goal, how do we move closer to that? But knowing that that may be what it takes to actually really protect that muscle mass. And protein intake, there's, again, a lot of range on this and depends a lot on the patient and the provider, but a minimal intake of 1 to 2 grams per kilogram body weight seems essential to maintain muscle mass. And many would argue that that is on the low end. It's recommended to consume protein more consistently throughout the day, so every 3 to 4 hours, because we do see that, especially in older adults, they may not get enough protein in all the meals. So they may get it at dinner, where we tend to consume, a protein source with maybe a vegetable and a starch, but their breakfast and lunch and maybe any other eating occasions throughout the day are very low in protein. So that's not going to be enough to get them to across the total intake that they may need. I've seen 30 grams about 3 times a day, so a total of 90 grams may be enough to promote and actually stimulate muscle protein synthesis. There's a lot more research and discussion I'm seeing on this bullet point specifically. Also, that high-quality animal source-derived protein may improve the synthesis of muscle mass. So that's not saying everyone needs a high, animal protein diet, but that we know that those proteins are, better quality protein, and if a lot of times, and so improving synthesis of muscle mass. It just, again, maybe a conversation to have. If someone's doing plant-based, they may have a much harder time, and they may need more to really build, again, synthesize and build that protein for muscle mass. And then thinking about leucine, one of the amino acids, that you may need about 3 to 4 grams per meal to achieve maximal stimulation of muscle in older people. So that would mean to get about 25 to 30 grams of total protein in a meal would get you about 3 to 4 grams of leucine in a meal. So that may be something also to just kind of think about what foods have that and where that lines up in what someone's eating. So back to that resistance-based exercise program I mentioned, counteracting the complications with increased fat mass and high body weight, we really want to do avoid that muscle mass loss through resistance training rather than just aerobic exercise alone. So even though, a lot of us practice on that, like some is better than none, we've got to do what you're going to do. That's all still true. But I do think we could be a little bit more aggressive or assertive maybe in moving folks towards actual strength training, safe, resistance and strength training within a calorie restriction kind of a component as someone's trying to potentially lose some of their adipose tissue, but preserve or maintain their muscle mass as well. So my conclusions, I've got 6 here. I think we'll talk through these and then have any time for questions at the end. But caring for adults with obesity, older adults, requires a definite focus on the whole person and an individualized or personalized approach. I would say that's for everybody. That obesity is fundamentally heterogeneous, so we're not all the same. Every patient you see has a different kind of story and different underlying mechanisms, etiologies, and so they have a unique prevention and treatment modality associated with that. Treating the disease of obesity and that intersection of aging, cognitive decline, adipose tissue, reduced muscle mass, and sarcopenic obesity, I hope, if anything, you appreciate how complex and nuanced that may be. and that our treatment approaches should focus on reducing weight and excess adiposity during midlife, with a focus on preserving and building muscle mass to protect against that sarcopenia that we see later in life. That obesity treatment modalities require a comprehensive approach that include nutrition, physical activity, behavior, sleep, and then pharmacology, surgery where indicated. And then finally, the assessment and monitoring should include body composition assessment, particularly paying attention to central adiposity, visceral adiposity, fat mass, muscle mass, and a lot of the metrics to assess co-occurring health conditions in the individual. So I do have quite a few references for you. I have a reference list specifically pulled out I can share. And these are at the back of the presentation that you'll have. These are the ways to stay in touch with me. And again, if you want to email me, if you had any trouble with the handouts, please let me know. You will be receiving email communication about, for dietitians specifically, continuing education, the slide deck, and then I'm working on a practice guide that will go along with this, so that if you want to refer back to some of the take-home messages in a written form, you'll have that as well. Okay, well, I'm gonna thank you all again for attending. Please do reach out. I really, as a clinician, most of my career now working with healthcare providers, I miss some of the patient stories. So please do send me any kind of questions you have about your individual patients or about how to apply this, and share anything by email, and maybe connect with me on social media as well to keep that conversation going. All right. Well, thank you all so much.